that we will be talking about avulsion today, and we will be talking this avulsion based on the current evidence and clinical management. So what happens, what is avulsion? First of all, we'll understand, and what happens to the subjects who get avulsed teeth and how do we treat such cases. So avulsion is actually after a trauma, as we saw in the picture previously. Patient, when gets injury, that results in complete displacement of the tooth. Means the tooth is intact, but it is displaced out of the socket. When it is displaced out of the socket, it means it got severe trauma, which led to destruction of its periodontal ligament, its neurovascular bundle, its neurovascular supply is cut off, and the tooth is avulsed, means tooth is displaced outside the oral cavity, or the tooth is displaced outside the socket. So this trauma can, trouble the pulpal region of a tooth. Definitely when the tooth is out or it is out of the socket, it means there is a breakdown of the PDL ligament and its relevant blood supply. So avulsion in simple means displacement of a tooth from its socket. As you can see in this picture, that this tooth is completely out of the socket, but the tooth is intact itself, and how we will manage, we will talk about it. So very essential thing, the literature says that we can save this avulsed tooth based upon so many factors. Number one, we have to see that how long did it got the trauma before. If the trauma has occurred 0 minutes before, or few seconds or few minutes before, you immediately replant the tooth. Replant means we are planting the tooth back into the socket. You immediately replant the tooth into the socket. But the viability of the PDL is very essential. This is actually some classification given in the literature on a viability of the PDL, how viable the PDL are based upon the time. If the time span is like less than 30 minutes, the injury has occurred in a less than 30 minutes time, you immediately replant the tooth and the result will be good. The outcome will be good. Yes, if the patient has reached to you in between 0 to 30 minutes, we can again place the tooth. PDL is still favorable, but the results are comparatively lesser than when the patient has arrived soon after the injury, means far before 30 minutes. So because what we are looking at, we are actually looking at the viability of the PDL. What actually structure that will help the tooth to get replanted and then again get new attachment with the socket will be the PDL, is actually the PDL. So the longer the time the tooth is outside the oral cavity, the tooth is prone to more a tooth is prone to more damage and more dryness, and the result is poor prognosis. But if the patient has reached to us early, before 30 minutes, far before 30 minutes, in a 0 minute or immediately, you immediately replant the tooth, you will get best results. But if the patient has reached to us in almost less than 30 minutes, some PDL is viable, the result is favorable, we can replant the tooth and we can have good results. But if the patient has come to you after 60 minutes, means after an hour or even few hours later, then usually the PDL is non-viable. Means the tooth, the surface of the tooth gets dry. It is, definitely patient doesn't know where to hold the tooth from. Patient will be continuously touching this tooth from this root region. Patient may, try to wrap it with the cotton or a gauze quickly or in a clothing. Patient may bring to you without, any transport medium. So these all things lead to decreased survival of the PDL, resulting in poor prognosis. So best prognosis is you try to have the tooth after avulsion. The patient should reach to you earliest possible. Okay. And in the severe injury, we can replant the tooth, but again, the basis of the replantation will always be the viability of the periodontal ligament. Viability of the periodontal ligament, it means is essential for replanting the tooth. So what determines the prognosis? Other than PDL viability, there are other factors that also determine the prognosis of the tooth is, first of all, extra-alveolar time. As we said, the PDL, how longer the PDL is open to the environment, how longer is the tooth is taking into the environment, because extra-alveolar means the tooth is not present into the alveolus, it is out of the alveolus. If the extra-alveolus environment will rise, the timings will rise, the prognosis will decrease. Number two, how did patient bring the tooth to you? In what storage medium patient brought the tooth to you? Was it brought to you in a storage medium, or was it brought to you dry? Again, it affects the prognosis. If brought to you dry without a storage medium, the prognosis is reduced. Again, you need to see root development. How is the root completely developed, partially developed? So it once again affect the prognosis of the tooth. Time of replantation. How early did you replant the tooth back? If you're taking longer to replant the tooth because patient did not reach to you early, or even at your practice, you are taking longer, like maybe you're performing root canal for a longer period of time, again, you are increasing the drier time. So it will again decrease the prognosis of a tooth. Other than these things, you need to see the socket where we are going to replace the tooth back. You need to see, is there any injury to the socket or not? If the socket is intact, then the replantation results are good. But if there is injury, any sort of trauma to the socket, it means that will again compromise the results of replantation. Then splint and endodontic management. Definitely when we place the tooth back into the socket, we cannot leave the tooth like that. We need to splint it by means of wires. So the splinting and endodontic status means whether the tooth is needing, if the tooth has got pulpal injury, we need to perform the endodontic treatment. How you are performing the endodontic treatment, how long you are taking to the endodontic treatment, how well you performed it, that is again essential in having an idea that whether we'll be going to have a good prognosis of the tooth or not. But these are essential things to see the prognosis. But basically, out of all these, this extra-alveolar time which was affecting the PDL matters more. If the PDL is viable, it means your PDL is preserved, your periodontal healing will be most likely. But if the PDL is necrosed, broken, then even if we replant the tooth, the end result will be ending with ankylosis of the tooth, resorption of the root, and the result, whatever we want to achieve, will be least likely or less likely. So good is try to replant the tooth earliest possible, and if patient is in contact with you soon after the injury, ask the patient to rush to you immediately. So now patient has come to you. What things you need to do after obtaining history and everything, you need to see first that whether age of the patient. If the patient is young, you need to first confirm the tooth is permanent or tooth is deciduous, because primary teeth are never replanted. We only replant the permanent teeth. Then when the patient has brought the tooth to you, do not touch the root of the tooth. Always hold the tooth from the crown. Never touch the root, because we know that the PDL viability will be compromised. Then rinse the tooth gently if dirty. If possible, replantation is possible and you see that the tooth is not dry, there is sufficient PDL present and the dry time is not more, and you think replantation is possible, then you quickly place the tooth in a storage medium till you are preparing the patient, till you are getting history from the patient, till you are asking the question from the attendant of the patient if the patient is young or a child. So till then you can quickly store the tooth in a storage medium. And we have different storage media we will be talking about. Essential things which you are supposed to do at your practice are: do not scrub the tooth. It will make the tooth much drier. Do not scrap the root. Let it be whatever way it is brought to you. Just wash it with irrigating solution or just dip it into the storage medium. Do not disinfect the tooth, and do not let the tooth dry for a longer period of time into the external environment. So again, we said that the timings are very essential in order to have a good prognosis and good outcome. So what are the different storage media we use. Storage media basically is used when quick replantation is not possible. For example, your patient has given you a call that doctor, my child has fallen and his tooth is the tooth with its root is out of its oral cavity. What you will ask the patient, because patient is maybe half an hour away from your house or maybe 1 hour away from your house, and you are maybe not available at your practice. So you are telling your patient, quickly place this tooth in a storage media. Normally the storage media which is available at home is milk. We quickly ask the patient, put the tooth in a cold milk. This is easy available storage media. But if the patient is adult, we ask the patient to keep the tooth under below the tongue, to keep it into the saliva. Okay. And the best storage media is HBSS solution. That's it. Hans or Hanks, somebody calls it Hanks, somebody calls it Hanks. Hanks balanced salt solution. This is the first rescue medium, but this is usually available into the hospitals or practices. This is not normally present at home. The thing which is present at home, we ask the patient to place the tooth into that storage media and quickly bring to us. When patient bring this tooth to us into the storage media, you quickly transfer it into the HPSS salt solution. Then some physiological saline medias are also available. We can place the tooth into the saline as well. Okay, this is another storage media. But this is acceptable medium, but not ideal or not a practical medium. And as the last resort, I told you that we can ask the patient to put the tooth into the oral cavity if adult. To the children, we do not say this thing. But we always ask the patient, and we ourselves even avoid to dip the tooth in a plain water as a storage medium, because it will destroy the PDL. And once the PDL is destroyed, as from the beginning I'm talking, that we will be losing the prognosis, we will be losing the viability. Okay. So in the real world option, we have milk as a media, storage media, when HBSS solution is not available to us. So when the tooth is brought to you, we have to see how the tooth is brought to us, what media has been used, and some studies also report that we ask the patient to put the tooth into the solution like milk and put it over the, put the ice over it. So whatever means the patient is bringing the tooth to you, and whatever way you are holding the tooth is actually that is actually telling us that what will be the outcome of the result of replantation. So first of all, in the sequence now we took the history. We need to see what storage media was tooth brought to you and what storage media do we have available. After that, we do the soft tissue examination. We go for the socket evaluation. We need to see the status of the alveolus. Is the alveolus intact, or is the alveolus suffering from any traumatic injury along with the tooth? We need to see periapical radiography in order to see again radiographically the status of the socket and the status of adjacent teeth. Quickly, we need to irrigate the socket before planting the tooth, replanting the tooth. We irrigate the socket to remove all the debris from the socket with the saline. After washing and removing the debris from the socket, we quickly take the tooth into the socket and we place it. But before placing, you need to have a good orientation of the tooth, that your orientation of the tooth is proper. So after proper orientation, we replant the tooth with slight pressure, always holding from the crown of the tooth, never from the root. After that, we confirm the position of the tooth. After clinically, we need to confirm it radiographically. But when we were cleaning the socket, when we were irrigating the socket, in this time, you do not curette the socket. You do not apply unnecessary pressure to the socket. Okay. Then once again, confirm from the patient that did the patient get the tetanus injection or not, because for the patient who for the subjects who get traumatic injuries, we quickly ask the patient to get tetanus injection, because the contaminants from the soil can produce could have contacted the tooth, could have contacted the patient, could have contacted the wound, would cause trouble to the patient. So as I told you, we generally take the tooth after not debridement, but after washing the socket. Then we place the tooth after confirming the orientation clinically and radiographically. Once confirmed, then we fix the tooth with flexible splint. These are called as passive splints. For normal avulsion cases, studies say that you need to apply this fixation for 2 weeks. But if it is followed by any alveolar injury, if any jaw fracture or any other small fractures to the particular region from where the tooth is avulsed, then we can add 2 weeks more into it. And the fixation from the flexible would change to the more rigid fixation or more rigid stabilization. So in a nutshell, we said if the socket is intact, no injury, only the tooth is avulsed, all is good, you provide patient with flexible fixation for 2 weeks. But if there is any other injury along with the avulsed tooth, socket injury, then we can add 2 weeks more into that, and we can give fixation for 4 weeks, but the fixation would be rigid one, not the flexible splinting. So after this, we ask the patient to avoid whatever the post-op instructions we give, but we ourselves also avoid rigid fixation and long fixation, because these rigid and long fixation will have then negative effects over the tooth survival. So if needed, we need to go for endodontic management. What we do if the apices are closed and tooth is mature, you go for pulpal evaluation. If you expect that there is a pulpal necrosis going to happen in a day or 2 or afterwards, then we initiate root canal within about 2 weeks of replantation, and we place the calcium hydroxide dressing into it, intracanal medication, to prevent from the resorption, inflammatory resorption that will be actually resulting after the infection. But if the tooth is immature with open apices or open apex, then revascularization is possible, because we know that the tooth is still immature and it is going to grow further if nicely positioned. So we try to avoid immediate RCT in such cases if there is no sign of necrosis, and we closely monitor the pulp. When we will be calling the patient on a follow-up visit, we have to evaluate the inflammatory resorption on these follow-up visits as well. And we perform the regenerative endodontics, but the results are not predictable. So if the tooth is prone to necrosis, perform root canal treatment, but when the apex is closed. But the apex is open, tooth is immature, and we know that there is no sign of necrosis, we avoid immediate root canal treatment. We monitor the patient. After careful evaluation, we'll be thinking whether we should go for it or not. Okay, so post-operative care, we give antibiotic to the patient. First, we need to take detail, as we took the detailed history before. In that, we have asked the patient for any allergies with the medication. Then, accordingly, according to history, we prescribe the antibiotic according to age and weight of the patient. The dosage is decided. Then we ask the parents if the child is young. If the patient is adult, then we ask the patient to use chlorhexidine, 0.12% rinsing for 2 weeks, because chlorhexidine is considered as a chemical, brush. Somehow you can say when a patient cannot perform the mechanical brushing. Soft diet for 2 weeks at least to avoid traumatic biting to the particular region. Especially, we ask the patient for the rest of the, only not to the affected area, then the rest of the healthy area, patient is supposed to clean that region with the soft toothbrush gently. Avoid contact with the spots after the replantation. If the patient has got any sports injury, we ask the patient to refrain from it, and we have to specially ask if the injury occurred on a road, on a soil, then there are high likely chances of tetanus, so we ask the patient to go for the tetanus injection. So what complication occur after replantation in months or a few or after years? There are possible chances that even after we have managed the tooth nicely and all, but there are chances that tooth may get pulpal infection. This pulpal infection may lead to resorption of the root, and that is called as inflammatory resorption. And this inflammatory resorption, or the tooth may undergo pulpal necrosis. And these tooth teeth with inflammatory resorption and pulpal necrosis, there are high likely chances that they will be ending up with ankylosis. And also watch the pulpal necrosis, infraocclusion in a growing child when the patient is young and is coming to you at different visits. So if you at the time you replanted the tooth, there was no pulpal necrosis, but at each follow-up you have to evaluate the radiographically and via clinically, that is there any pulpal necrosis going to happen, or it is initiated. We need to see if the tooth is in, when the child is growing, tooth is in normal occlusion or is it into the infraocclusion. We need to see, is there any marginal bone loss that is occurring around the tooth, any discoloration, any mobility, and these all things we need to confirm on every visit. Because these, why do we call patient on follow-up? Because these are the things which actually we need to evaluate on every follow-up to see the end result of the replantation, to see the prognosis of the tooth in a longer period. So survival of the tooth basically does not mean that the tooth, we replanted the tooth and it is healed. No. Survival of the tooth means when you are coming, patient is coming on a follow-up from months to year to you, there are no clinical and radiographic changes present around the tooth. It means the tooth is surviving. And you need to confirm them at different intervals, at second week of replantation, at 4 week, third month, 6 month, 1 year, and up to 5 years. Because we cannot say that I will only see the prognosis of a tooth for 2 to 3 visits. No, we can keep such patients for years for the follow-up to see whether we are going to get a proper outcome or not. Okay. So at review, at every appointment, when the patient is coming to you, you have to see the symptoms of infection, mobility. You need to go for percussion test. You need to see gingival status, pulpal status, PDL space via X-ray, periapical changes via X-ray, root resorption via X-ray. So these all things are need to be evaluated at every visit, and these are to be documented in the patient's document. So evidence says that immediate replantation is a gold standard. Immediate means when the patient has come to us quickly, before 30 minutes, it's a gold standard. Delayed replantation may still preserve static function and future options, but the prognosis may be compromised. So the points to ponder are: quick implantation means immediate implantation. Handle the tooth carefully from the crown, not from the root, to protect the PDL. Use HPSS solution. If not available, then we can protect, or we can use milk. Use passive flexible splints for 2 weeks if there is no any injury to the socket. If socket injury, we can add on the weeks and we can change flexible splinting to the semi-rigid splinting. If the apex is closed, start root canal within about 2 weeks, and if open apex is there, then monitor the revascularization, whether the tooth is getting revascularized or not. Long-term follow-up is very essential because resorption and ankylosis may appear later in such teeth. So never re-implant the avulsed primary tooth. These all the things are for the permanent teeth, not for the primary teeth, because primary teeth, we know that they are supposed to shed off, and permanent teeth we cannot compromise. So again, the prognosis depends upon your extra-oral dry time and how quickly you replanted the tooth. Thank you so very much. For any contact, for any problem, any query, you can WhatsApp me on the given number, and you can share your reviews via email through given email address. Thank you so very much. Inshallah Ta'ala.